at Dana-Farber, although transitioning to a faculty role there, and has a great interest in this topic and is the focus of his research right now. And I think it's a broadly interesting topic and something that's coming up more and more as a consideration for some of our patients in hospice and palliative care. So we're grateful that you could join us. Thank you very much. And yeah, tell us a little bit about yourself and then go get started.
Awesome. Thank you, Suzanne. And thank you I really appreciate the Boston chapter of the HPN and to having me this morning. It's a very exciting topic, very rapidly, there is a rapidly growing interest in furthering the research of psychedelic-assisted therapies in psychiatry in general, or in medicine. And in particular in patients who deal with serious illness and death and dying. So I just want to thank you for being here this morning. It's a special morning to make a presentation. I know many of us might have our thoughts concerned by the ongoing news, actuality. So hopefully we can plug into this fascinating topic, maybe get some excitement, and even this might cheer us up a little bit because there are lots of nice research and therapeutic promises in this field. I'm Yvan Beaussant. I'm a French-trained hematologist and palliative care physician. So I did my medical school and clinical and research fellowship in France before moving in the States a few years ago to further my research interest in psychedelic-assisted therapies. I had like more than 10 years of clinical practice in palliative care before coming here. And I had really a special interest and concern about how to address the amount of existential distress that I could experience or face in my clinical practice, and for which we don't have clear guidelines or therapeutic tools to offer patients and families who express these kind of concerns, and how related it is to lots of psychosocial distress that we see in our practice. So when I became more aware about this research work that was reopening in big centers like NYU, UCLA, Johns Hopkins University, I was willing to further my research on that. Nothing was going on in France at that time, and it's a very stigmatized research area, of course. And so it was easier for me to come in the States and to study this than research it in France. And so in 2018, I applied and entered the California Institute of Integral Studies training, the Certificate of Psychedelic Therapies and Research, to get some training in this kind of in psychedelic-assisted therapy and research. And I entered the Psychosocial Oncology and Palliative Care Research Fellowship. So I'm just in the last day of my research fellowship now, after 2 years of training, and now transitioning as a faculty at Dana-Farber. And I'm really excited to speak and to initiate this discussion with you this morning, because we are one of our research focus here at Dana-Farber is really to try to develop a novel therapeutic model of psilocybin-assisted therapies in patients who receive hospice care. So I'm especially interested to have your feedback and thoughts regarding this particular interest. So I'll just stop here for the introduction and I'll go ahead and start. So does that work? Can you see the next? Yeah, so I have no potential conflict of interest here. And so really the objectives for today is to bring a little bit of background about the history of therapeutic use of psychedelics, to maybe have a few slides to get us a little bit more familiar about the basics of pharmacological, neurobiological, and psychospiritual mechanisms of action of psilocybin. And I will mostly focus on psilocybin because it's the most psychedelic compound, the most studied in patients with serious illness. Then we'll see we'll go over the evidence that exists of psilocybin-assisted therapy in patients with serious illness, and explore the current perspectives on potential roles and the priorities in patients with serious illness in the research field. And then I'll say a few words about research perspectives in hospice care. So psilocybin in particular, but belongs to a pharmacologic category called psychedelics. And the term psychedelics literally means mind or soul manifesting or revealing. And this term was coined by Aldous Huxley in the 50s in a correspondence with Humphrey Osmond. So psychedelic-assisted therapies combine an inner-directed psychotherapy to the consciousness expanding properties of psychedelics. Here you can see different psychedelics: LSD, psilocybin, DMT, and MDMA, which is a little bit in a different category, but have similar effects as well. And so this combination of the drug and the psychotherapy is meant to facilitate processing and resolution of psychological and existential issues in individuals. So in the world of Michael Mithofer, who is a psychiatrist and the PI of the ongoing phase 3 trial of MDMA-assisted therapy in patients with PTSD, he says, combining the powerful effects of pharmacology with the potential depth of psychotherapy is a compelling mode of harnessing advances in neurosciences and psychopharmacology without ignoring the complexity, the richness, and innate capacity of human psyche. So, and I really want to emphasize on the last part of this, because psychedelic-assisted therapy is really as much a pharmacotherapy than a condition and a set and setting that facilitates people to find their own resolution or own resources to face whatever they're struggling with. In fact, it's quite a simple treatment, and that has been around for more than 3,000 years in religious and healing rituals. So just a few historical perspectives here, or dates. So as I just said, it's around since quite a long time in different cultures, in therapeutic or healing rituals. And in our biomedical model, really it starts around in the 1940s, when a Swiss chemist, Albert Hofmann, discovers the psychoactive properties of LSD. Then it's not long before the first LSD studies in humans start. And in between the 50s, the early 50s and 1965, there are more than 1,000 studies on addictions, end-of-life anxiety, cognition, behavior, and actually LSD is the most studied pharmacological compound ever, if you look at all this literature. And so then the same chemist will synthesize psilocybin in 1958. And then there is this historical period of time where psychedelic compounds are going to go out of the medical field and being used by a lot of people recreationally. And so this will be associated with counterculture movements and the Vietnam War protests. And so it's in a very political way, it will become a control substance and prohibited after the Controlled Substance Act in 1970. So there is then more than 20 years of research halt, of clinical research halt, before slowly at the end of in the 90s, clinical research is starting again. And so we'll talk more about that after. So here I'm going to focus again on psilocybin-assisted therapies for the sake of time, and because it's the psychedelic medication that is currently the most studied in patients with serious illness. So psilocybin is present in nature in psilocybin mushrooms, also known as magic mushrooms. And traces of rituals and use for religious and healing purpose go as far as 3,000 years before Christ. And it is still used as a sacrament in many cultures, traditional and modern cultures. So as I said, the chemist Albert Hofmann isolated psilocybin in 1958, and he synthesized it a year later. And so the potential to relieve suffering in patients with serious illness has been researched since the early 60s with the psychedelic therapies. And so we'll see this more in details in a few slides. But it's one of the potential therapeutic applications of psilocybin that has been studied the earliest, and that has drawn many researchers' interest. So a few words about the pharmacology, which is really well known for psilocybin. So it has like a 50% bioavailability, meaning that it's like half of what you ingest will be metabolized and pass the digestive tract. Sorry. Psilocin is the active metabolite of for the 5-HT2A activity of psilocybin. It's detectable in plasma within 20 minutes after administration of psilocybin, and the half-life is 2-3 hours, meaning that after 6 hours, there is hardly any compound in the body. And 65% are excreted in the urine, and 15 to 20% in the stool. So in terms of dosing and physiologic effect, a classical dose for what we call a high dose or of psilocybin will be taken orally at 0.3, 0.4 milligrams per kilo. It's a very safe drug for the body, and it's hardly impossible to overdose psilocybin. Like there is no LD50 known in humans for psilocybin, and like the dose to kill a mice with psilocybin is just like enormous compared to the therapeutic dose. The onset of noticeable psychoactive effect occurs within an hour, and the peak effect will generally occur within 2 hours. And the effect will follow the pharmacokinetic of the drug and will be lost around 6 hours after ingestions. So usually the implications for therapeutic use will be that there will be an 8-hour observation, 6 to 8 hour observation during the effect of the medication. So psilocybin, as I said, is the active metabolite of psilocybin, and it acts as an agonist of the serotoninergic receptor 5-HT2A. The activation of these receptors lead to a release of glutamate and a neuroplasticity that might explain some of the effect on consciousness and some of the therapeutic effect, and especially in terms of the ability to change pattern of thinking or behaviors because of this neuroplasticity. And in neuroimagery, researchers have found that psilocybin inhibited what is called the default mode network, or the DMN, which is responsible for a sense of self and the task-driven functioning of the self. So when you're very task-oriented, your default mode network is very present. And what happened with psilocybin is that the control by the default mode network is released. And this default mode network, as shown here, controls many of the pathway between brain areas. And when the DMN is released, then many new or latent communication pathways are allowed to occur in the brain. And that explains some of the psychological effect of psilocybin, and especially the synesthesias, which means, like, for example, seeing sounds or hearing colors. And so this is really because there are new communications allowed between different areas of the brain. So now on the subjective level, or the phenomenology level, so it's the level of subjective experience. And what's most described is that psilocybin profoundly alters perception, emotions, thoughts, and a sense of self. But all this with a preserved vigilance. So it's not at all a sedative drug. It preserves vigilance, but it alters these different other functions of cognitions and perception. And most individuals report a powerful psychospiritual dimension of this experience. And that seems to have a lasting impact on relationship to self, to family, to others, to community and society at large, to nature, and to the significant or the sacred. So this has all the attributes of what researchers call a spiritual experience. And the intensity of the psychospiritual breakthrough is also positively related to positive outcomes. I will show maybe more data on that later. So this is an interesting study in healthy volunteers that was done in 2008, published in 2008 by the Johns Hopkins group. They have really pioneered a lot of the very interesting clinical research on psychedelics. And here they gave a high dose of psilocybin to healthy volunteers, but on a blinded way. So they could receive either psilocybin or an active placebo, methylphenidate. And just to show that this, again, the powerful effect of this psychospiritual experience, because it's the first study where they correlated the intensity of this mystical or spiritual experience during the psilocybin session with positive outcomes. And here you can see that more than 60% of their participants rated this experience as among the top 5 personally meaningful experience of a lifetime. And more than about 70 to 75% rated this as in the top 5 spiritual significant experience of a lifetime. Here it's about the current personal well-being or life satisfaction that was increased following this experience, and the positive behavior change, also very highly rated by most of the participants. So what is this spiritual experience? It's usually named, so it can have different names, like here, some call this a mystical-like state of consciousness. Others will call that non-dual experience, other peak experience. And some of the characteristics of this experience are the following: a sense of unity, meaning a strong sense of the interconnectedness of all people and things, meaning that sense that all is one, and it's a self-transcendence in that regard. Then there is a noetic quality, which is a term that was coined by William James, and that means a feeling of profound insight or intuitive knowledge with tremendous force of certainty. It's like more real than reality, the taste of this experience. There is a strong sense of sacredness and intuitive response of awe, humility, holiness, reverence, and wonder in the presence of whatever is around, and inspiring reality. There is a deeply felt positive mood with joy, blessedness, peace and love to an overwhelming degree of intensity, and ineffability. Experience is felt to be beyond words, non-verbal, and impossible to describe. And so there are measurement scales that measure the intensity of such an experience when after either occurring naturally or after psilocybin or other experiences. And so what this study show is that the intensity of how people rate this kind of experience is correlated to positive outcomes afterwards. So now what is psychedelic-assisted therapy? So it's really using these mind-expanding properties of the psychedelic compounds with the facilitation of an inner experience by trained therapists. And so here really the treatment safety and efficacy has been developed in the 60s and really depends on what we call the set and setting. And the set is like how prepared an individual comes to the experience, and the setting will be all the factors in the environment and the social environment and the physical environment in which the experience will occur. And all this is of paramount importance regarding the quality and the nature of the experience that will unfold. So very important factors are the screening, and especially screening out people who might have contraindications, and I will come back on that. The patient preparation, the psychological and spiritual support by trained therapists or guides during the experience, and then a few sessions of integration to help the individual make sense and incorporate the insights of this experience into their real life. Sorry. And so this is an interesting graph that was shown by a neuroscientist a few months ago here in Boston. And it highlights the importance of the context, so again, the set and setting, to achieve long-term positive outcomes. And so again, it shows the relationship between the subjective experience and the long-term outcomes. And then it shows that the quality of the subjective experience is influenced by several factors related to the set and setting, including the emotional support in a large measure. So emotional support, the music has a strong importance as well. The rapport that the individual was able to create with the guides or therapists, therapeutic intentions, some childhood trauma and trait absorptions were also correlated with this kind of experience. In terms of safety, so again, the safety is good in a controlled setting and a therapeutic context. It's very well tolerated on the body, and like the studies that we'll review afterwards, in advanced cancer patients really show no serious adverse events and usually transient and very moderate adverse events. But we still have to learn more about how this can be safely used, especially in our population. It's non-addictive products. The biologic independence is virtually impossible with that because of a tachyphylaxis of psychedelic compounds. And then the psychological safety, again, really depends on the quality of the set and setting in which individuals will have this kind of experience. And so in a controlled setting with preparation, screening out of contraindications, and proper guidance, the psychological safety is really excellent. And I didn't have a special slide on the idea of bad trip, but the idea of bad trip is really when the intention of people who take psychedelic drugs is to have fun or to have a good experience. And then challenging material is coming up, and they will be fighting against this material because that's not the experience they want to have. But in a therapeutic setting, it's completely different because this kind of challenging psychological material will be what the therapist and the individual will work with during the session. And the encouragement from the therapist will be to welcome this kind of material and to sit with it and to be present with it in a very open and curious way to allow the experience to unfold in a natural way and to process. So it's the concept of bad trip is not really relevant in a therapeutic context, if you may. So in terms of adverse events, so during the dosing sessions, the people might describe trance and anxiety. Some negative emotional states might occur, like anger or sadness or fear. And again, this will be probably part of the therapeutic process to welcome and experience these emotions during the sessions. This might be also paranoid or delusional thinking during the sessions. And again, they're psychedelic therapists are trained to deal with this kind of experience. On the physical level, the most described adverse events are increased blood pressures and heart rate, mild nausea that are usually just at the onset of the drug effect, and subacute headache more at the end of the effect. No serious adverse events reported in healthy volunteers and patient studies so far, and this is thousands of patients. And adverse events generally classified as mild and resolved within 24 hours. After the dosing sessions, no long-term adverse events are identified in control studies. So there is the so-called HPPD, hallucinogen persisting perception disorder, that has some description in people who are regular users of psychedelic drugs, but not in the control studies. Yeah, so no, in control studies, no HPPD, no drug abuse, and no psychosis are described. Sorry. And this slide shows data about the non-addictiveness of psychedelics and the large therapeutic index. So this is a table that shows different psychoactive compounds with on the horizontal bar the active dose and the lethal dose here, which is the more on the right you go, the more dangerous for the body the drug is. And here's the dependence, the ability of the drug to induce dependence. And you can see that, so the most dangerous and dependence inducing will be heroin, followed by alcohol or morphine that we use like daily in our patient population. And here, like LSD and psilocybin are probably the less toxic and the less inducing of dependence here. And this is kind of the same idea on this graph, that here psilocybin is really, this is like the potential for self-harm in blue, and the potential for harm to others in red. And you can see that the psilocybin like hardly cause any self-harm or harm for others. So now I'd like to focus maybe more on psychedelic-assisted therapies in patients with serious medical illness. I'm just gonna check time. Okay. So these therapies have been evaluated in patients with serious illness since the early 60s. And from 1964 to 1977, two teams really published original reports in this population. Eric Cast's team from the University of Chicago School of Medicine, and the Spring Grove State Hospital's team, including Walter Pahnke, who was a Harvard psychiatrist, Stanislas Grof, and Bill Richards, who is still in function at Johns Hopkins University. And he's a psychotherapist and one of the early researchers of this field. So Eric Cast's papers. Eric Cast was a psychiatrist and an internist at the University of Chicago School of Medicine. And he conducted studies with LSD in terminally ill patients. And so in the first study published in 1964, he compared LSD to oral opioids in 50 patients and looked at the effect on pain, but without much emphasis on psychological support or psychotherapy. Despite that, he found that LSD had a greater efficacy than opioids in relieving pain, and he reported no serious adverse event. However, he also observed that because of the intense psychological effect that LSD induced, it was quite difficult to use as an analgesic agent, and that many patients didn't want to renew the treatment even though they found it beneficial. And so in his further studies, he kind of shifted his perspective and area of focus with these compounds. And because many of these patients reported a positive effect on anxiety, mood, and fear of death, he conducted a second series of experimentations published in 66 and 67 with 80 and 128 patients respectively. And in these open label trials, he spent more time and efforts in the preparation of patients and the psychological support. And he measured improvement in pain perception, again, but also in mood, fear of cancer diagnosis, and death anxiety. So at that time, he was in touch with this second team that in the late 60s and early 70s really developed the therapeutic model that is still in use today with psychedelics. And this is the team of Dr. Kirkland at the Spring Grove State Hospital in Baltimore. And they conducted, again, open label trials of psychedelic-assisted therapies in patients with advanced cancer. They developed the therapeutic model that we still use today, and in which the set and setting are really considered as crucial determinants of the safety and efficacy. And so they reported substantial improvements of symptoms such as anxiety, depression, fear of death, and a sense of isolation following high dose of LSD in this supportive setting. No serious adverse events were reported, but considering the fatigue induced by LSD sessions in these patients, they decided to use another compound called dipropyltryptamine, DPT, which is like a short-acting psychedelic drug in a subsequent study. And in this study, the correlation between mystical experience and clinical improvements was first described. So, and regarding LSD, so now in today's studies, we focus more on psilocybin, which is quite in between LSD and DPT in terms of length of action. Classically, an LSD experience will last at least 8 hours and might last even more. So it's very impractical in a clinical setting to use LSD. And so psilocybin is more amenable to a day session, with patients. And so during the same period of time, as you know, important cultural transformations were happening that were more or less related to psychedelics. And despite the promising results of early studies, the passage of controlled access substance in the 70s made these drugs illegal, and clinical research became increasingly difficult and stigmatized. Just of note, in 1992, John Early Match, who was the former assistant of Richard Nixon, the US president who intensified the war on drugs in the 70s. And so John Ehrlichman, he notoriously admitted that the administration had lied about the harmful effect of these drugs, and had manipulated media coverage of these compounds for political advantage. And so nearly 50 years later, psychedelic drugs remain more legally restricted than heroin or cocaine, which are Schedule II, compared to psilocybin or other psychedelic compounds, which are like Schedule I substances. And really the reasons underlying that was that the Black communities or the peoples of color were using these drugs, and the counterculture, people associated with counterculture were also using these drugs. And so criminalizing these drugs were a way that they found to get them out of the picture and imprison them, because they were troubling for political reasons. Anyway, that's the whole political slide I will have. So then when Charles Grubb at UCLA and colleagues resumed clinical research in this population setting in 2004, over 25 years had passed since the last psychedelic session to a cancer patient had been administered at the Spring Grove Hospital. And so some of you may have read these papers published between 2011 and 2016. And I will focus here on the 3 studies conducted more recently with psilocybin in cancer patients. And this was at UCLA, at Johns Hopkins University, and New York University. So the similarities between the 3 studies are the following. These were double-blind design methodology using randomizations among groups and active placebo control. They used validated outcome measures to measure clinical outcomes, and they administered a single dose of moderate to high dose psilocybin. They used crossover methodologies, meaning that patients were their own control, and they blindly they had 2 sessions, but they were blinded about which one was the placebo first or the psilocybin first. And important psychiatric exclusion criteria relating to major mental illness also are similar in these studies, and in particular psychotic spectrum illnesses or a family history of these disorders. So which is like the main contraindications for psychedelic experiences, personal of or family history of psychosis. Patients were carefully prepared by trained therapists in dyads after a thorough life review and review of their cancer diagnosis and its negative psychological and existential impact. Dosing sessions were occurring in a comfortable setting designed for optimal safety and comfort. And instructions were set to participants were really designed to increase the likelihood of inducing this spiritual experience or mystical experience of consciousness. And that means that people are really encouraged to focus inwards during the experience and to lie on a couch with eye shades and to focus on their inner experience. And they have like a music program played through the dosing sessions through earphones. And then a last very important element was a few sessions of integration of the experience after the dosing session as part of a post-integrative psychotherapy. Some limitations of these studies were the following. These are relatively small samples, 29, 51 patients in the studies with the most patients, not powered to determine efficacy, highly selected populations, heterogeneity of the samples with respect to psychiatric diagnoses and cancer diagnoses and staging, and also a lack of data on other psychosocial interventions received by patients and whether on how psychosocial and palliative care needs had been addressed by specialized teams prior to their inclusion in these studies. So, but anyhow, these are important studies because they were proof of concept. They proved the feasibility and the safety of these therapies, and it's becoming much more easier to study nowadays thanks to these studies. So just a few results of 2 studies. This is Charlie Grove studies, the UCLA one that included 12 patients with advanced stage cancer, and they had adjustment disorder with anxiety associated. So as I said, randomized double-blind active placebo-controlled crossover trials. They used a moderate dose of psilocybin, which then were increased in further clinical trials, but the FDA didn't allow. It was the first study really reoccurring in patients, so the FDA didn't want to allow a higher dose. So now we use more like 20 or 25 milligrams per 70 kilos because it's more effective. And so despite this small number of patients, patients had 30% decrease in the Beck depression inventory scores and significant decrease in trait anxiety that were sustained at 6 months. This is the NYU study in which psilocybin was associated with enduring anxiolytic and antidepressant effect with 60 to 80% of participants showing continued reduction in depression or anxiety. And that were sustained benefits in existential distress and quality of life. They had improved attitude toward death at the 6 months follow-up as well. So this is before crossover and after crossover. So like you can see the real difference is really between these two crossover, and then after the second group has the psilocybin experience, they usually join the first group. And these the coefficients, Cohen's d coefficients, reflects the effect size of the intervention, which was really huge compared to other psychosocial intervention that we have in this patient population. Generally, we are happy when we have like this coefficient is around 0.3 or 0.5, means that we have a significant effect of psychosocial intervention, and that is, but here more than one reflects just a very strong efficacy. And in Griffith's study, 80% of participants showed clinically significant decrease in depressed mood and anxiety at 6 months follow-up. And 70% were in remission of their depression, and more than 60% in remission of their anxiety disorder. And these were people who rate quite high in depression and or anxiety scales at the beginning. So no medical or psychiatric serious adverse events were reported, and the adverse events that were reported in the studies are comparable to those I presented before. With I'll just show like so the elevations of blood pressure and heart rate were non-clinically significant, but present in 76% of patients. 28% of people had headaches or migraines at the end of the sessions, and people had like might have nausea in a few at the onset of the drug effect. So both Ross and Griffith's results were mediated by the mystical experience questionnaire score, which is one of the questionnaires that measures this intensity of this spiritual experience. And so they came up with this conceptual mediation model for the effect of psilocybin, which has a direct pathway through the pharmacological action of psilocybin, and an indirect pathway which is mediated by the intensity of this subjective experience. So just 2 slides about qualitative studies that has been conducted in patients, in the NYU patients, the NYU study patients. So they were able to interview 13 patients that participated in the study. And some of the major themes or themes that occurred in all patients they interviewed were the following: like this idea of interconnectivity or relational embeddedness, that we are all part of the, connected with everything around, was of major themes. The emotional range of the experience during the psilocybin session, meaning that people described going through intense joy or intense sorrow or fear or anger, but they really experience a very wide array of emotions during the experience. Then the role of music as a conveyor of experience was also a major theme. Meaningful visual phenomena, wisdom lessons, revised life priorities, desire to repeat the psilocybin experience. So these were really common throughout the interviews. And then other typical themes were exalted feeling of joy or bliss, feeling of love, ineffability, alteration to identity during the psilocybin experience, embodiment, from a sensation of being separated to interconnectedness, difficult struggle, experience of transient psychological distress were described in 7 patients. Loved ones are as guiding spirits, and then sharing the experience with loved ones, etc., etc. This is a very beautiful study. I really encourage you to read it. I can send the references after. Like, there are 2 papers on this qualitative study, but which is really, really rich. And so some of the words coming from these studies, I felt my family was doing their best and that people tried as hard as they could. Even people that weren't there for me did their best, and certain things from the past were in the past, and that was okay.
I'm watching this is a webinar.
I felt this constant state of becoming. I felt gratitude like I never felt before in my life. I felt totally welcome.
Makes me want to, like,
I think somebody has to make sure the mic is off.
Just overcome with love and all the love that I have.
If you're not muted, if you could please just mute yourselves while the presentation is still going on, that would be great. Thanks.
Thanks. Another young patient was saying, these lamps are part of me. They're part of my past. There is no reason why I should hate them, accept them, and take care of them. Less afraid of death. Death is part of life. Death is not important. This changed my life. And so this study was published a few months ago at the beginning of the year. And it's a long-term effect study with the follow-up was at 3.2 and 4.5 years in 15 patients out of the 20 that were still alive at that time. And the study showed a large and significant reduction in anxiety, depression, hopelessness, demoralization, and death anxiety in these patients. Improvement in spiritual well-being. 60 to 80% of participants continued to meet criteria for clinical antidepressant or anxiolytic response and remission. And 71 to 100% of participants attributed subjective experience of positive changes to the psilocybin-assisted psychotherapy experience. So it's only 1 drug session and a few sessions of psychotherapy that seems to have this kind of lasting effect, at least in some patients or in these patients. I think we're at a point now where there is a lot of excitement about these preliminary results, and we have to look through research what it looks like in real life, or maybe in less selected patients and more generalizable studies. So maybe I'll go quick over these, but this is a study we conducted 2 years ago, interviewing experts in serious illness care about their perspectives on the potential role of psychedelic-assisted therapies in the care of seriously ill patients. And so we interviewed experts from palliative care research, oncology, psycho-oncology, spiritual care research, and psychedelic-assisted therapies. And we really try to include researchers or experts with a variety of opinions on psychedelic-assisted therapies, including naysayers or people who had expressed skepticism. And so what I'm presenting here is reasons for enthusiasm, skepticism, and concerns about this research. So 3 main reasons, we found 3 main reasons why participants express enthusiasm. First is a potential new tool in the toolbox of professionals like us caring for patients with serious illness, where currently available therapies may sometimes be disappointing. And so it's different in the way that it combines a psychosocial and a drug intervention, which is a novel paradigm in the whole medical field. And that the therapeutic effect seems at least partly related to the profound subjective experience induced by the intervention. And so for many participants, the psychedelic-assisted therapies had the potential to really get at the core of it, quote unquote, meaning that it had the potential to address psychosocial distress at a deep existential level. Second, participants mentioned the promising results reported in recent clinical trials that we just saw. And third, some participants highlighted how these therapies seem really to align with palliative care or hospice philosophy and goals in terms of striving to improve patient symptoms and quality of life, to improve coping skills, to improve healing relationships to self and others, and to empower patients with serious illness in deciding for themselves or making like highlighting their values. Skepticism was related to the idea that these results presented in the studies we just saw were kind of too good to be true, that these studies had limitations, that warranted a cautious attitude, and that for some, however strong the therapeutic effect might be, only a small proportion of patients with serious illness would be willing or able to engage in this kind of therapy. So this will be also an area of research. And then concerns were expressed because of patients' vulnerability in serious illness care. They worried about physical and psychosocial adverse events in this patient population, especially if this therapy were to become more available. Some participants worried that the psychotherapeutic part of this intervention will be decreased because of issues or commercialization issues, and that might heighten the risk of adverse consequences. And finally, they expressed concerns related to the mind-altering effect of psychedelic drug and the potential for abuse. So this, we have already a lot of literature that can be bring to this kind of concerns. So in terms of research priorities, I think really what's important now is to document and research what are the indications for these therapies, in what population of patients, what is the efficacy, on what outcomes, what are the mechanisms of action, what are the potential toxicities and adverse events in a larger scale control trial, and what's the impact on healthcare and system level. And so here we're working, I'll show this a little bit later, but in terms of patient population and establishing indication, we will be really looking at the hospice population here in the study we're working on. The participants we interviewed also indicated the need to research the following aspect of the therapy: the amount of psychotherapy, the appropriate number of therapists per session, whether the group therapies are feasible and efficacious, what drug in what circumstances, what dosage in what circumstances, and what kind of psychotherapeutic approach suits best. The participants articulated potential indications in seriously ill patients, which are the following: anxiety, depression, existential distress, demoralization, hopelessness, adjustment disorder, certain form of pain. So all these, really, we're at the beginning of a huge research efforts that is needed in this field. And the potential outcomes, relevant outcomes to study might be the following: patient-reported outcomes, including symptom burden, quality of life, as well as survival, caregivers' outcomes, decision-making, healthcare service utilization, etc., etc. So these are my last slides, and I just would like to highlight some of the potential applications in patients receiving hospice care. So more than 1.4 million Americans receive hospice care each year, of whom about 30 patients have cancer as their primary terminal diagnosis. Over 50% of patients were cared for at home, with 42% cared for nursing home setting. And the median length of stay is 24 days, with an average of 71 days of length of stay. So this is like the US data on hospice patients. And because of the intrinsic model of care, hospice care might offer an ideal container or frame for psilocybin-assisted therapy to be delivered in a proper way. And that's because hospices follow a whole person approach, which is rooted in the biopsychosocial and spiritual model. And they work at rapidly establishing good communication and trusting relationship, which is really crucial in psychedelic-assisted therapy as well. And they follow up patients and families' needs very closely. So when it comes to patients with serious illness or terminal illness, it seems what has been developed in the hospice field is just what this kind of therapeutic approach needs in terms of setting. And there is a clinical need. End of life is an existential crisis by definition for patients and families. And for most patients and families facing end of life, of course, emotions such as fear, anger, or sadness are common and normal to experience and to express. And however, 38 to 50% of patients experience clinically relevant distress, such as anxiety or depression, that will significantly impact their quality of life and their caregivers' quality of life. High quality hospice care ought to seek as a fundamental goal to address this psychosocial distress, and yet symptoms such as depression are often under-recognized and under-treated in this population, as shown by some studies. This may be due to clinicians or patients not recognizing depressive symptoms in the context of a terminal illness, to the lack of effective treatment, or both. And there is, in addition, existential suffering, which is commonly experienced at the end of life, and that may exacerbate anxiety or depression. And also, finally, the symptom burden is heavy for family caregivers too, with clinically significant symptoms of depression in 23% of them, and anxiety in 33% of family caregivers. So improving the management of these symptoms would benefit the healthcare outcomes of a high number of patients and family caregivers. And it's exciting to see this novel therapeutic approach coming up. And so here, we are currently collaborating with Suzanne and their Care Dimensions teams to develop the PATH study, which means psilocybin-assisted therapy in hospice. And the goal of this study is to assess the feasibility, the safety or tolerability, and the preliminary efficacy of psilocybin-assisted therapy in 15 patients who receive hospice care at home. So patients will have like a PPS greater than 50 and a moderate to severe demoralization, which will be our primary efficacy outcome. The treatment will include like 2 preparation sessions, 1 psilocybin session, and 2 integration sessions that will be delivered by IDT members, hospice care staff. So we're very excited to work on this pioneer project, and we really hope that it will help other hospice teams to develop their own programs. And so I think that's my last slide, and I'm really, really interested to hear your own perspectives on this topic and welcome your questions if you have some. And thank you again for being here this morning. Oh, and this is just to make one piece of advertisement regarding the only academic training for therapists currently existing in psychedelic-assisted therapies. So this is the Center for Psychedelic Therapies and Research, which is based in California. But the exciting news is that the program is developing on the East Coast and here in Boston. So I think admissions are open until November 30 for the 2021 cohort. So if some of you are interested, I encourage you to go visit their website. And it's really a fantastic, very thorough and comprehensive training that has already trained like more than 400 psychedelic therapists, and we'll need more. So thank you again for your attention. I'll just maybe stop sharing. How does that work?
Thank you very much. So I think this morning we have, 21 minutes left in the morning. And so to open the floor up to questions, if you want to ask a question yourself, please feel free to do that. Just unmute yourself. And then if you prefer to type it in the chat, then you can do that and I'll help moderate it that way. We did have one question, Yvan, that came up during your talk from Joanna. And Joanna, I didn't know if you wanted to ask it yourself or if you want me to do it. Either way is fine. So I will go ahead and ask it. And Joanna, if you want to jump in and add anything else, go ahead. But she had asked, what tools are used to get the neuroimaging?
Great question. So I think mostly fMRIs, functional MRIs and electroencephalograms. Is that how you say? EEG? Yeah, EEG. EEGs. So these are the main tools that are used to get an idea of what's occurring at the structural level on the brain. I'll just mention the work that's being developed now at MGH. There is a multi-million funded center that is opening at MGH on the neurosciences of psychedelics. So this is happening right now. And so they have really three pillars in this program, and one of them is neuroimagery. And I think fMRI was invented at MGH, and they have like machines that nobody else in the world have. And it will be very exciting to see how they're going to study psychedelic experiences, putting healthy or patients, healthy volunteers or patients in fMRIs during psilocybin experiences, and really looking in depth about what's happening during this kind of experience. Yeah, and the other two pillars of their program are, of course, the clinical applications in psychiatry and especially depression. They have a strong research program on ruminations that are associated with depression, and it seems psilocybin-assisted therapy has interesting clinical applications to help with ruminations. And then their third pillar is the neurobiology, and so they'll be developing novel psychedelic drugs or compounds based on their studies on the neurobiology of psychedelics.
Thank you. And Joanna did have a follow-up aspect to her question, and she said, and one of her other questions is, why is another drug chosen as a placebo? Doesn't this mix up the more clear results that are found with non-medication placebo?
That's a great question. I think it's a really tricky aspect of this research, the placebo questions, because in most studies, it's been very easy for both the individual and the therapist to guess which compound was the placebo, or which, of course, so what they've tried to do is like using active placebos, meaning so niacin is like a nicotinic agent that kind of provoke a kind of a flush at the beginning and some sense of dizziness, or so they're trying to use things that might confuse a little bit this because many of the participants are naive of psychedelic drugs, so they don't know what to expect, so they it's harder to guess. And other studies have used small doses of the same psychedelic compound as a active placebo. I think so. We've done a seminar at the beginning of the year with a bunch of researchers and experts in the field to discuss about how we should move this field forward in patients with serious illness. And one of the output of that was that definitely we need studies that compare psychedelic-assisted therapies to standard of care, and regardless, even though we won't have we won't be able to blind the procedure, which have some inherent biases, but I think we need studies that compare, just like Temel's study had compared early palliative care to a study to oncological care, to standard oncological care, you know, and we had two arms. Study were not, and so academic it's a matter.
I had a question. The original studies were with just volunteers, and the more current studies are with hospice patients, not palliative patients. Right? I'm trying to figure out if this is more within the quote 6-month prognosis, or if it's a more general population, as far as the more recent studies that were done with those incredible results.
Sure. Yeah, so in these studies that we've seen the results of, you know, there were really a mix of patients, with some with advanced cancer and some with not advanced cancer. Even some patients had local, you know, local cancers. So I think now some of the critics on these studies were saying we need more homogeneous populations to study, and so that's what several teams are trying to work on currently. And so I told you about the study, the small feasibility study that we're working on specifically in a specific population of patients receiving hospice care. So we'll be really focusing on patients who already receive hospice care at their home, and we'll focus on people who are fit enough to receive psilocybin and to hopefully get the treatment and fill out the forms that we need them to fill to assess the outcomes. So that's the window that we're targeting in this study, and hopefully, and I'm curious about your thoughts, whether you think this is realistic and feasible, you know, in given the population that you know. But that's the edge that we're really trying to develop a therapeutic model that will be amenable to patients who receive hospice care at home. And we don't know the answer. So that's why we are conducting the study. And other teams are working on different patient population. There is a team in Maryland who is working on patients with all cancer, but who have like major depressive disorder as a psychiatry diagnosis, and like externally assessed by psychiatrists. So they have like the major depressive disorder, and they're actually treating their first cohort of 4 patients tomorrow. So today is the day where they're preparing the patients, and one of the novelty of this study is that they will be administering the psilocybin simultaneously to 4 patients at a time. So patients will be in individual rooms with one individual therapist each, and there is a lead therapist that is supervising the 4 treatment sessions. But so it's a cohort of 4 patients who receive psilocybin at the same time, and so they're prepared today as a group and individually with the same group of 4 patients with cancer and MDD, and then they'll have like group integration sessions. So it's a very interesting, novel therapeutic approach that is really studying like today. And another group who works in the palliative care setting will be starting in the upcoming months or next year a multi-center study with palliative care patients who receive palliative care, and they will compare standard palliative care to palliative care plus psilocybin-assisted therapy. So they won't focus that much on terminally patients as we'll be doing in the hospice population here, but probably more patients a little bit more early in their disease trajectory or end of life. So I think all this is valuable in terms of conceptual framework when it comes to analyzing the feasibility, the safety, the efficacy of these therapies in different specific populations that have serious illness, but that might have like different, might be at different stages of their serious illness.
Just a quick follow-up, and
Yeah.
you're talking about home hospice patients. If setting is a big component of this, would you be doing it in the home, or would you have them go to, you know, a controlled location with?
Yeah, that's the latter. Yeah, but that's a good question. I didn't specify that. So what we're doing is we're preparing the preparation and the integration sessions are happening at patient's home, at the patient's home. And the psilocybin, the day-long psilocybin session will be occurring in a controlled setting at the hospice house. Yeah. But that's a good question. When I discussed with some of the other psychedelic researchers, some of them suggested that we might try to do some, you know, the treatment session, that we might try to do it at home for some patients. I think we're not there yet in terms of regulatory approvals, and I think it might bring some additional challenges in a study that is already complex and challenging to set up. So, so I think that should be explored in the future, definitely. Yeah, it would be interesting for. I think it's always interesting for people to revisit their home and their context with this different state of consciousness, you know, and to maybe part of the experience. So we'll see. I think we're fortunate to have a great setting at the Care Dimensions Hospice House, and I think it will be really a wonderful setting for people to have like this experience in a neutral setting, very beautiful and very safe. So that's how it will happen. Yeah.
We have another question that's come in from Angel, and she's asking, what is the vision on how a team will be trained to administer and facilitate the session? How effective can you be as a facilitator if you have not experienced psychedelics?
That's fantastic questions. So the vision for the training, I don't know if the question is regarding this specific trial or later down the road when there are many, maybe more centers that are starting this kind of work. But I think both sides of the questions are interesting. And so here, we're really thinking hard about that currently. We're having a talk, so we'll be working on that with the non-profit company that is delivering the drug, that will be manufacturing and delivering the drug, USONA Institute. It's a non-for-profit research organization. They synthesize psilocybin, and they are currently conducting a multi-center trial in patients with major depressive disorder in the general population with psilocybin-assisted therapy. So they have developed, in collaboration with the CPTR, the training in California that I mentioned earlier, they have developed a training program for their therapists and a treatment manual. So they train the therapists to implement and conduct this kind of therapy. So we'll be working with them to adapt their therapy manual and their therapist training to our specific population. We know that the ID team member, the hospice team members that will be working on are already trained in delivering high quality palliative care. And this involves many of the skills that are expected for psychedelic-assisted therapy. So I'm not very worried about people being able to embody what is needed to be a good therapist in this realm, you know, and we'll be adding a little bit of specific training that comes from, you know, the science of psychedelic-assisted therapy and the science of the therapy itself, to to just to get them ready to sit for patients and to help prepare and integrate patients. And then the questions regarding the own personal experience is really a good question. I think most of the people who work on this field acknowledge that it's important for therapists to at least have an experience of non-ordinary state of consciousness and maybe some kind of spiritual practice to appropriately deliver or sit or provide therapy for patients who go through this experience. So this might be meditation practice, this might be holotropic breathwork or breathwork practices, this might be yoga practices, and this also might be some experience with psychedelics in an intentional and guiding way. So, but this is a tricky question because there is no legal pathway to train therapists currently that way. That said, organizations like MAPS or other organizations have been able to directly train their therapists with a direct experience with psychedelic-assisted therapy within research protocols. So meaning that they included their therapists in healthy volunteer studies, and they had arrangements with FDA that they will use their future therapies that they were willing to train in their healthy volunteer studies that will provide safety data that they needed, and that will provide some training for the therapists with a first-hand experience of psychedelic-assisted therapies. So this is where we are at now. I think everybody acknowledged that things have to evolve in a way that will allow the future therapists that would be willing to have this first-hand experience to have it. But it's not required. It will. I don't think it will be never required. But what will be requested from therapists is to demonstrate, a good skills for relationship, being able to sit for patients whatever occurs for them during the psychedelic session, and some familiarity with non-ordinary state of consciousness, whether they're induced by drug or not.
Thank you. I think that's a very interesting aspect of all of this in terms of the role of the therapist or the clinician or the person who's assisting. So it's 9:27. I have one quick question, and Joanna had a follow-up question. My question is looking at this, looking at caring for people who are dying, who deal with who can be challenged with very intense suffering around the death anxiety or the demoralization or hopelessness. Right now on a criteria, they're going to be excluded either by functional status or, their ability to leave their homes and come back and tolerate a day of, really controlled therapy. But with the immediacy of effect and even a duration of effect for 2 weeks for somebody who's very near end of life, I think that it could be hugely beneficial to reduce that kind of suffering, and to the point of the caregiver, improve the grief experience of the bereaved, to know that was alleviated for their loved one. So I hope over time, when there's more safety data and with more data, that it will be expanded to be able to be provided to patients who are much more close to death with a lower functional status. So that's just my commentary. Joanna had a question in regards to, Joanna, if you want to ask about how to get involved, was that right?
Yes, that's right. I'm just interested in being more involved in this work, and who would I contact?
Yeah, I didn't put the link. Let me put it in the chat. There is a great research group in Boston, actually, the Boston Psychedelic Research Group. So I invite you. Let me put it in the chat here.
They just had a great lecture series last week or the week before on
And there is
expand
another
on
one on the 12th,
Yeah.
which will be on this topic actually by Tony Bossis, one of the therapists of NYU. So I really encourage you to connect with this group. It's a wonderful group of diverse people, some researchers, some therapists. Let me see. Nicole, I think it seems I can send it only to you.
I
Can
still
you?
have those settings just talk, but I will. There's the link for everyone
Okay,
for the
great.
Boston Psychedelic Research Group. And
So, yeah, researchers, therapists of the Boston area, and now much beyond that because of the Zoom aspect, you know, like everybody's moving online. So now it's like many members from all over the place connecting, because there is really a great quality. Like every other month they have a special guest and small group sharings about this topic. And it's a great network of people who are interested in this field. And there is a special interest group on seriously ill patients. So that might be a great way to connect and maybe brainstorm about projects and ways to get involved in that. Yeah.
thank you very much.
Thank you so much, Yvonne.
Thank you so much, Yvonne. It was really terrific. Really great.
That's awesome.
Perfect.
Thank
Yeah.
you very much.
Thank you.
Thank you.
Yeah.
Exciting stuff.
Bye, everybody. Have a great day. Yeah. And
you.
finger crossed. Huh?